Hello, thank you so much for the opportunity to speak today. I'm going to be speaking about the treatment of autoimmune encephalitis in pediatric patients. Our learning objectives for today are to review a little bit about how pediatric autoimmune encephalitis is different from adult disease. We'll review why the workup has to be done before treatment is initiated. And then we're going to dive into the review of management of pediatric autoimmune encephalitis, in particular looking at the time frame and response to first-line therapies, such as steroids, IVIG, and rituximab. Review the indications and time frame when to escalate treatment, discuss the importance of supportive care and symptomatic treatments, and then discuss a little bit about the recurrence of symptoms outside of an AE flare. So first, we're going to start with how you diagnose autoimmune encephalitis. And obviously, we're going to build here on what Dr. Gorman has spoken about before. But I just wanted to highlight a little bit of how pediatric autoimmune encephalitis differs from adult criteria. When looking at the adult criteria, you'll notice that they focus more on distinct phenotypes and that adults tend to have more classic presentations that really help differentiate between different types of autoimmune encephalitis. In addition, their diagnostic criteria focus mostly on three clinical manifestations, primarily short-term memory loss, altered mental status, and psychiatric symptoms that are really key in the diagnosis of adult disease. The pediatric criteria needs to acknowledge, though, that children are at different developmental stages based on age, and that how they present with autoimmune encephalitis and their ability to communicate or show those manifestations will differ. A 2-year-old with autoimmune encephalitis is likely going to look very different than a 15-year-old with autoimmune encephalitis. And so there's a broader array of clinical symptoms that are included to make one think about autoimmune encephalitis as a possible diagnosis. And this broader group of symptoms include altered mental status or EEG changes, in particular EEG changes with slowing or focal or epileptic activity, focal neurologic deficits, cognitive difficulties, acute developmental regression, so loss of skills children used to have, such as language, ability to toilet on their own or other independent skills, movement disorders, excluding tics because tics are so common and just part of normal childhood development, psychiatric symptoms, and seizures not explained by a previous seizure disorder. I want to pay special attention here to cognitive difficulties, as this can be really challenging to differentiate from some of the cognitive changes that you may see in people with a primary psychiatric condition. And I think this is really important because there is an overlap with psychiatric symptoms, both in autoimmune encephalitis, but also many times is one of the manifestations that makes people think about autoimmune encephalitis and new onset of psychiatric symptoms. And so it's really important to help differentiate if those cognitive differences are because of a primary psychiatric symptomatology or if there are cognitive differences in addition to psychiatric symptoms. And I think this is really important when you think about anxiety or OCD. It's basically asking kids to be doing extreme multitasking. So when kids have a lot of anxiety or OCD, a good part of their brain is very focused on thinking about either that loop they're stuck in or worrying about something or being very fixated on a particular sensation or needing to do something just perfect. And so in the middle of trying to read or learn something in class and pay attention, part of their brain is starting to distract them and pull them over to think about those other things or get focused on those other things. So it's not uncommon that those children will then have trouble remembering what they just read or remembering what the teacher just said. And it's important to differentiate that difficulties with paying attention or that distraction from true cognitive differences. And so because of that, in the pediatric criteria, there is that emphasis on really needing a neurologist, psychiatrist, or neuropsychologist to evaluate for this criteria to count and consider doing neuropsychiatric testing. Some psychiatric conditions can cause a small drop in your IQ. So for this diagnostic criteria, you have to have greater than a 20% drop because really we're looking for a more significant change that we typically see in autoimmune encephalitis. In addition to those symptom differences, the term possible is used a little differently in the adult versus the pediatric criteria, and I think it can be a real confusion when we get to talking about the treatment of autoimmune encephalitis and if the patient has a true diagnosis, quote unquote, true diagnosis of autoimmune encephalitis or not. So in the adult criteria, they tend to use the term possible autoimmune encephalitis after patients have already gone some component of a workup. So their possible diagnostic criteria includes patients with CSF pleocytosis, as they've counted more than 5 white blood cells, or MRI changes suggestive of autoimmune encephalitis. And they give kind of the specific changes they would expect to see in that situation. For pediatrics, One of the challenges that we recognized was that it is often hard to know when to even initiate a workup in children. And so these criteria for possible was really made with the idea that you would be helping clinicians decide when it's worth or when you should be thinking about doing some invasive studies like a lumbar puncture, or even an MRI in children, which may require general anesthesia in addition to the lab work. And so the term possible autoimmune encephalitis in pediatric criteria is really just an entry point into the diagnostic workup and should not be considered a diagnosis in and of itself. And obviously thinking about Dr. Gorman's talk to highlight some of those differences. But I think this becomes really important when you're thinking about treatment because as an adult disease, especially when children are very sick, you may initiate therapy with first-line treatments while you're waiting for some of the results of your workup to come back. But we don't want to anchor too much on this possible AE diagnosis otherwise. So when we're talking about possible autoimmune encephalitis versus seronegative autoimmune encephalitis, this is an important differentiation that patients sometimes have trouble knowing what we meant when we said it was possible, and now we're saying, no, you do not have autoimmune encephalitis. And there's sometimes this confusion that seronegative autoimmune encephalitis means you had symptoms that could be consistent with autoimmune encephalitis, but the workup was completely negative. And that's not actually the case. Seronegative autoimmune encephalitis means that there was other changes that are showing signs of CNS inflammation and autoimmunity. You just don't have one of the known anti-neuronal antibodies. And this is different than not having anything that's positive on your testing. That doesn't mean that there isn't something going on. You may have a primary epilepsy syndrome. You may have a genetic syndrome. They may have PANS. They may have, some other primary condition. It just wouldn't fit with autoimmune encephalitis. And so when we're making the diagnosis of seronegative, we're looking at symptoms that are consistent and at least one of the markers of CNS inflammation or autoimmunity, and that big box of excluding other alternate diagnoses. It's important to remember that an atypical presentation of a more common childhood neurodevelopmental disease is going to be more common than autoimmune encephalitis in most cases because the autoimmune encephalitis is rare. And so I think what we have to acknowledge here is the gray zone, where we have children who have symptoms that could be consistent with autoimmune encephalitis that have some changes on their testing, but aren't part of the ones that are considered to be more specific and would meet the criteria for autoimmune encephalitis. So these may be children who have an elevated opening pressure on their lumbar puncture or an elevated protein in their CSF, or children who have PET scan changes that could be consistent with autoimmune encephalitis, but we don't have enough data to really be confident about that diagnosis. And in these situations, that box of excluding the alternate diagnosis gets really big because we really have to be thoughtful that we're excluding all of these other conditions that could mimic autoimmune encephalitis, referring to Dr. Gorman's talk again here. So Heather, why are you focusing so much on the diagnosis of autoimmune encephalitis at the start of your talk on treatment? And one of the reasons is because being confident about our diagnosis before we initiate therapy is really important. A lot of times people say, can't we just start steroids or IVIG? We'll see if people get better, and then we can do the workup after, because I don't want to do a lumbar puncture if I don't have to. And the problem with that is that immunotherapy will change the results of some of that testing, and sometimes pretty quickly, and really impair our ability to make an accurate diagnosis. And those treatment effects can both give false positive and false negative results. So steroids tend to work quite quickly. They can change MRI findings of enhancement within hours of a dose. They can change levels of antibodies and white blood cell counts. Steroids are known for killing white blood cells really well. That's why high doses are used in cancer treatments. So you can change those numbers pretty quickly. Steroids can also help with seizures or other conditions that's not due to inflammation. They can stabilize neuronal membranes. So it is a treatment that can be used in refractory epilepsy at times. So improvement for those, the effects of steroids are much broader than just anti-inflammatory. IVIG, on the other hand, instead of covering up something, may add something artificially. So IVIG is pooled antibodies. So if you have antibody testing that's positive after receiving IVIG, that may not be your antibody. That may be what you received when you got the IVIG. In addition, IVIG can cause aseptic meningitis. So if you do a lumbar puncture after someone has had IVIG, it's unclear then if those white blood cells you're seeing are because of the inflammation that existed before IVIG or are an effect of the IVIG. And then plasmapheresis or plasma exchange, the whole purpose of that is to remove antibodies, which is going to make antibody testing more difficult. So as painful as it is at times, it's really important to complete the evaluation and be as confident as we can be in the diagnosis of autoimmune encephalitis before we start treating. And that's because many kids need escalation of therapy to more strong immunosuppressants that have more risk with them. So when we think about the treatment goals of autoimmune encephalitis, we're looking to decrease inflammation, but we're also looking to control symptoms, maximize functionality. The goal is to ideally achieve remission and control that inflammation long-term by maintaining remission with the eventual goal of getting people off of medications. How do you decide which treatments to use, when to use them? That's a little more complicated, and there's a lot of work being done in that. But right now, we tend to use a couple broad categories that help us determine which medicines to add and how quickly. The first has to do with what subtype of autoimmune encephalitis you have. Some tend to be more steroid responsive, such as Hashimoto's encephalopathy, and others are known to be more aggressive and refractory, such as GAD65-associated disease. Duration of disease may play a role. This has been going on for a long time. One of the questions that will come up is how much of the current symptoms are due to active inflammation and how much that may resolve with or improve with immunotherapy, and how much of that symptom is due to sequelae from past inflammation that may not be as responsive to immunotherapy and may depend more on some of that symptomatic management. And then what are the targets of our symptomatic management? We often talk about, treating the underlying immune response is a key component of treatment for autoimmune encephalitis. We can't ignore the symptoms that patients have, and we really need to be aggressive about relieving suffering from those other symptoms with medications that we typically use for seizures or other psychiatric manifestations or movement disorders. Even if they don't work quite as well often in the beginning with immunotherapy, they tend to work better and better. And it's important that we're doing everything we can, kind of targeting all the different pathways and mechanisms to improve the symptoms and reduce suffering while we're waiting for full immunotherapy to kick in. So my goal when I'm starting treatment for a child with autoimmune encephalitis is to give the lowest risk medication for the shortest duration of time needed for the maximum benefit and recovery. And we're always trying to balance the risks of the disease versus the risks and the benefits of the potential benefits of a medication. Treatment, as many of you know, is broken up into first line, second line, and third line treatments with first line therapies including corticosteroids, IVIG, and plasma exchange. Second line therapy typically is rituximab, Cytoxan, and then oral agents, mycophenolate mofetil, and azathioprine can also be used. And then third line therapy, this is kind of getting into a little more complicated area as new medications come online. One of the more common ones probably used is tocilizumab, and then bortezomib is being used increasingly as well. There are many different agents that can be used once you start hitting third line therapy, depending on different providers' comfort with different medications. In 2021, there were best practice recommendations put out for the treatment of autoimmune encephalitis that were really targeting both adult and pediatric patients. And a lot of the treatment overlaps in terms of the considerations. And as we work through this table, you start with a patient who has possible autoimmune encephalitis, especially if they have severe disease. You're going to go down a little bit different pathway than those with moderate or milder symptoms, as we talked about. And that has to do with you're trying to balance the potential risks of these medications that can get more risky the more kind of regular you go down second versus third line therapy versus how severe the disease is. And really, again, trying to give as little medicine as we can to get the benefits and return the patient to their baseline as possible. And so this is, I think, a helpful algorithm as kind of a first pass to look at. You may notice here that there is no recommendation of IVIG, Plex, or IV steroids necessarily over one of the others, especially in more severe disease. Many patients will start first line with steroids as first line therapy, reserving IVIG for more significant moderate to severe disease, and reserving Plex or plasma exchange for more severe disease. And partly, especially in pediatrics, we have a challenge with Plex because it requires central line placement, which often is going to require sedation or intensive care unit, or at least hospitalization for patients if they're going to be plexed over time. It gets a little more complicated. So most pediatric providers for treating autoimmune encephalitis in the mild to moderate AE group would use IV steroids and IVIG first and reserve Plex for their more severe cases. Both in pediatric and adult disease, the steroid dosing is 30 milligrams per kilogram up to a gram per day. And that is given in 3 to 5 days, subsequent days usually. It can be extended in severe cases. IVIG is usually given as 2 grams per kilogram over 2 days, usually in pediatrics, but can be up to 5 days. I see it more commonly spread over the 5 days in adult patients. And then usually maintained for patients who have a definite diagnosis of autoimmune encephalitis with monthly infusions for some time following, depending on how quickly they respond to therapy and recover, and if they're started on other medications. Plasma exchange is usually done as 5 to 10 cycles. Some institutions will do 5 days in a row. Others will do every other day for 10 days, and that can be repeated. One thing you'll notice here is you'd like to choose one or the other of plasma exchange or IVIG, as when you do plasma exchange, you pull off your IVIG that you just gave. It's quite expensive medication. So if you're going to start IVIG, you're going to want to give usually at least a week to see if the patient shows some signs of improvement. One of the benefits of first-line therapy, steroids, IVIG, and plasma exchange, is that if they're going to work, they usually work quickly. So ideally, when you start these medicines, you're going to start to see improvement within 10 to 14 days. And if you're not seeing improvement in that timeline, especially in the more severe patients, many people would consider that an indication to escalate therapy. So when we look at when we're escalating to that second-line therapy, hospitalized and critically ill children, usually 10 to 14 days will give to see the benefits of that first-line medication. This is most agreed upon in the NMDA literature, but we kind of extrapolate to other forms of autoimmune encephalitis as well. Sometimes I'll hear people say, well, we gave a dose of IVIG and then we need to wait a couple of months to see the effect of that one dose. And that would not be typically how we would think of that treatment as working for a true autoimmune condition. And so usually you're looking at sustained dosing over time when someone is started on IVIG. In patients who are being managed outpatient, who have that milder phenotype of autoimmune encephalitis, usually you're going to give 2 to 3 months to really give the full effect of that first-line therapy to see how it's working for patients. But you may need to escalate sooner than that if they decline. Or at times, if we're seeing improvement, but it doesn't last the full month, as they get toward the end of that month, week 3, and IVIG and steroids start wearing off, that can be an indication that that autoimmune process is still ongoing. We're kind of covering it up somewhat and managing somewhat with these first-line therapies, but we're not really getting at the underlying driver, and it's kind of sneaking back up as those levels of steroids and IVIG drop. And sometimes that is in itself an indication to escalate to second-line therapy. Second-line treatments that are most commonly used, I've mentioned rituximab in the past, and looking at that algorithm published for best practices, you'll find that in most situations, people will go to rituximab as the next line agent after first-line therapy. Some patients get Cytoxan and rituximab together. Those tend to be the much more severe ICU-level patients. And Cytoxan is used more commonly in adult autoimmune encephalitis than it is in pediatric. Several surveys have shown that pediatric neurologists and rheumatologists tend to prefer rituximab as the medication over Cytoxan. For less severe disease or antibody-negative, seronegative disease, where you're not sure it's really antibody-mediated process, thinking about MMF or azathioprine can be good agents too. The benefit of those, they are very strong immunosuppressant and work very well for autoimmune diseases, but they're nice in that they're oral agents, so you can start them and stop them. If you have a patient that's had issues with infection or some other reason where you're worried about giving something as long-term as rituximab. And that's because once you give rituximab, you can't ungive rituximab. Rituximab is going to stay in your system for quite a while. It usually lasts 6 to 12 months in most patients. Some pediatric patients especially can kind of chew through their rituximab a little faster. Their bodies metabolize it more quickly. And so while maintenance dosing for rituximab, if you have a patient who's a more slow recovery, had more severe disease, you may be looking to give subsequent doses. The most frequently we would usually do that is every 6 months. But usually around 4 or 5 months in, we'll start checking their B cells to see if they started to repopulate, and if so, dose that rituximab earlier. This can be really helpful, especially if patients are having some increased symptoms, to look and see if those B cells have repopulated. It's important to note that the B cells, when you see them in the serum, will have already repopulated in the tissues before that. So if you're seeing an increase in symptoms, even if that B cell repopulation is only 1% and still low, that still can indicate that that rituximab has worn off, and that would be an indication to think about redosing. For clinicians here on the talk, I would say if you notice that your patients are repopulating early, it's really helpful to get rituximab antibodies, which are commercially available now, to see if the patients developed antibodies to rituximab, as that's going to cause them to chew through it much faster, and it may be an indication that they need to switch agents to a different medication. And then maintenance medication, you can also, again, think about these oral agents, especially if you're not wanting to immunosuppress the patient quite as much, as they can be used for long periods of time. Not all patients with autoimmune encephalitis need to go on maintenance therapy. So some patients recover quickly with first-line therapy. Some patients get a dose of rituximab and their disease gets under control within 4 to 6 months. They're doing really well, and you may not need to redose that. So that really is a patient-by-patient decision right now. When to escalate to third-line therapy, this gets a little trickier. It's a little bit less clear guidelines on when to consider that and how much time to give your rituximab or those second-line agents to work. Our practice is to try to give 2 to 3 months to give a chance for rituximab or Cytoxan to see if it's going to be beneficial before escalating to third-line therapy. By the time you're getting to a decision about escalating to third-line therapy, usually patients have had active disease for some time. And so it's really, again, important to revisit this idea of what symptom am I targeting? Is this from active inflammation, or is this residual from either injury or part of the recovery process? And to continue to revisit that, given that not all patients will have full recovery and people can have some residual symptoms. And this is really challenging. And so these are definitely the patients where we are often re-imaging, getting another lumbar puncture, repeat EEGs, repeat neurocognitive testing, really trying to better understand what degree of this is active inflammation versus sequelae from the disease or just ongoing recovery. The other thing I always like to make sure we're looking at is, are we maximally dosing second-line therapy? So what dose of IVIG and steroids have we given? What dose of rituximab have we given? Have we been checking to look for a repopulation? Is that a reason why they seem to initially be improving, but now they kind of have plateaued or are worsening? So that we can make sure we're not missing an opportunity to maximize the therapies they've already gotten and have the risk they've already seen. So I just wanted to end with a few cases to kind of highlight a few of these things we've talked about today. So the first is an 8-year-old male. He presented with a 5-minute tonic-clonic seizure. It occurred about a week after a gastrointestinal illness with vomiting and diarrhea. His initial onset, his mom described as these bad dreams. He also was more aggressive, which was not his nature at all, with really aggressive behavior towards his family members. And then he started hallucinating. Mom described him as just talking out of his head, talking nonsense, talking to things that weren't there. He was taken to an outside emergency room when he had the seizure with an EEG that showed some questionable epileptiform discharges, and he was discharged home on trileptal for new seizure disorder, which had followed with neurology. Unfortunately, his behaviors continued to worsen. He was getting more aggressive. They initially thought maybe it was a side effect to his anti-seizure medicine, so changed that. But he just continued to decline and was eventually admitted for an evaluation. This is an example of his bad dreams that he was having. And what you'll see on this video is he's trying to get up and move around. He's got a raking motion with his hand. His mom is talking to him, not talking really any purposeful language back. You'll notice his eyes aren't even really open. And then he's going to slump back down. And he never was necessarily fully awake, but looked like he's back to sleep again. And on EEG, these were actually temporal lobe seizures that he was having. That mom had described as these bad dreams. And they were very stereotypical. They were happening the same way each time. And he would do this many, many times a night, 20, 30 times a night, over and over again with that same kind of behavior. So over the course of his hospitalization, he continued to worsen. And you can tell he was hospitalized because he has the EEG leads on his head. And he had more episodes of these continuous non-purposeful movements, hallucinations, and then some of these zombie-like periods that his mom would describe. So in the first video, you'll see he kind of starts with this movement of scratching around his mouth that will continue as this video progresses. And then he starts tracing an object in the air. He's kind of clearly hallucinating at that point. He's not really responsive during this period to any comments by his mother. In the second video, you'll notice that he starts posturing with his arm kind of being elevated and raised up. He could stay in that position for quite long periods of time. This is a manifestation of catatonia, and this is a really classic feature of NMDA receptor encephalitis. So our patient's evaluation, when he returned, demonstrated 44 white blood cells in his CSF on his lumbar puncture. His MRI was normal, but his EEG was consistent with temporal lobe seizures, and that, as I demonstrated there in that initial video. He had an extensive infectious workup, which was negative in basic laboratory studies that were all normal, and his CSF and serum eventually came back with positive for NMDA receptor antibodies, and he was given an official diagnosis of NMDA receptor autoimmune encephalitis. He was treated initially with steroids for 3 days and IVIG and showed some symptom improvement on IVIG, nowhere near to his baseline, but was starting to be more interactive. He was actually able to go to the playroom briefly, although a lot of agitation and abnormal behaviors persisted. He had increasing agitation and some of the psychotic type symptoms, some hypersexual behavior, which can certainly be seen with autoimmune encephalitis. And once his NMDA results were known and he was not showing significant improvement in that 8 to 10 day period of time, with some decline after his initial improvement with IVIG, he was getting more agitated as we approached day 10. He was indeed treated with rituximab. From a symptomatic treatment perspective, his initial agitation had been treated with an antipsychotic, but once he developed more classic catatonia type features and his diagnosis of NMDA encephalitis was known, he was changed over to clonazepam and Ativan for his catatonia, with improvement, although that continued to be a significant manifestation until approximately 3 weeks after that first rituximab was given. He was treated with several anti-epileptics and maintained primarily on Trileptal and Keppra at the end. He developed sleep disorder and started on melatonin for that, and ended up being hospitalized for 26 days at our institution after transferring from an outside hospital. So pretty long hospitalization. He then required ongoing rituximab. He actually received several courses of rituximab every 6 months, as he was quite slow to fully recover from his disease. He went to both occupational and physical therapy as part of his recovery, and his kind of recovery took quite some time, but I am happy to say he has now been flare-free and doing well off of all medications for several years, and graduating high school and just doing phenomenal. So our next case is a 13-year-old previously healthy male that woke up about a week after having a vaccination with these extended crying, like hysterical periods, incredibly anxious, in this real state of panic, as mom would say, and these episodes lasting up to 8 hours, and just expressing his desire not to want to live like this, just really distraught. At the same time, even in the periods where he wasn't in these kind of panic states, he was not really able to read anymore or do any basic handwriting, was not able to write his name, was confused, started having both visual and auditory hallucinations, and complaining of pretty severe daily headaches that were non-positional but persistent throughout the day, sometimes would be present on awakening. He was having significant difficulty sleeping, sometimes not getting more than an hour or two of sleep at night for extended periods of time. And then about a week into the symptoms starting, he developed these episodes with behavioral arrest and lip smacking that would last for 30 to 60 seconds several times a day. His evaluation revealed a little elevation in his von Willebrand's factor antigen and a positive thyroid antibody. He had a normal MRI. His EEG showed slowing, in particular right temporal lobe slowing, as well as background slowing. He had a normal CSF studies and normal serum and CSF autoimmune antibody testing. His neuropsych testing, though, was really profound, with impairments really across all cognitive domains, including verbal and nonverbal, problem solving, verbal fluency, mental flexibility, visual spatial, motor coordination, and visual motor integration. And his full scale IQ was a 68, or the second percentile. And this is a 13-year-old previously been a straight A student in school. So really pretty dramatic changes. And he was diagnosed with Hashimoto's encephalopathy based on his seizures, which our neurologist felt like those episodes and that were witnessed was consistent with seizure, his thyroid antibodies, and the normal MRI and LP, which is often seen in that condition. He was treated with steroids initially, as Hashimoto's encephalopathy is classically described to be quite steroid responsive, and he did have a good, robust response to it with 50% improvement. But given how horrible I just described him, obviously that was not a sufficient treatment response. And so after about 6 weeks of steroids, he was treated with IVIG, again with an increased interval improvement, but he was not back to his baseline. And he also started to show a pattern where around week 3 or so, he was making good gains, and then around week 3, we start to see some reemergence of more difficulty paying attention, communicating. His verbal skills would decrease some, and more of that anxiety worry would pick back up again. So he was actually started on mycophenolate about 6 months. So we initially added steroids and the IVIG, and then looking for that sustained improvement. And with the addition of the MMF, he was able to taper off of steroids and IVIG. He was treated for about a year with MMF after coming off of IVIG and steroids with no flares, and was able to taper off. He was also at the same time treated concurrently with an SSRI, given the degree of anxiety and panic he had. It's symptomatic treatment for that. That dose was started at a lower dose and escalated over 6 weeks to the typical therapeutic range needed for anxiety, which is often higher, what I've learned from our psychiatrist, than treating depression. So he got up to a pretty robust dose of that and tolerated it well. And he was maintained on that until after he came off of immunotherapy. He returned to his premorbid levels of functioning and was able to taper off all medications. And this is just some examples of his, the top left corner is his work pre-illness. And then as you move kind of clockwise, you kind of come into the 1-2 o'clock quadrant. This is him as he's become quite encephalopathic. And then when you go down below that, that's him relearning to write his letters and numbers, then starting to write in short sentences. Then starting to answer questions, do schoolwork again, things like that. And this was his last visit, his picture that he drew for our group, back to himself and feeling like he was engaging with his peers and academically doing really well again. So I look forward to chatting with you more during the question and answer session, and I'd like to thank you all for your attention today and for the opportunity to speak. I'd also like to give a shout out to my team here at Duke. I have a fantastic nurse practitioner, Krista, my colleague, Carolyn Pizzoli from neurology, who really taught me a lot over the years on how to help take care of these patients. So thank you.